All right, well, welcome everyone to our February IPHA let me start that again. Welcome everyone to our February COVID-19 Town Hall. I appreciate everyone for joining us this evening, and we've got a good group already logged in. I'm sure we'll have some join us here in a couple of moments, but I want to make sure we're respectful of your time. So I'm going to turn tonight's topic over to Dr. Christy Bettram from Rosalind Franklin University and have her take us on through her program. Go ahead, Christy.
Thank you so much. Can you just confirm you can see my slides and hear me all right?
We can hear you and we can see the slides.
Perfect. Everyone, good evening, and thank you to IPHA for inviting me to speak tonight. Like Garth said, my name is Christy Bertram. I'm Assistant Professor of Pharmacy Practice at Rosalind Franklin University College of Pharmacy, and I'm also an Infectious Diseases and Antimicrobial Stewardship Clinical Pharmacist at Northwestern Memorial Hospital in Chicago. This evening's presentation is titled BAM BAM What? Understanding the Role of Monoclonal Antibodies and Convalescent Plasma in COVID-19. And really the inspiration for this title came from myself, and I'm sure all of you as you first attempted to pronounce the names of these new monoclonal antibody agents. If you could please save all of your questions until the end, I'll try and leave some time then to answer any questions you may have. Before we get started, I wanted to mention that I do not have any conflicts of interest to disclose, as stated on this slide, related to anything that will be discussed this evening. By the end of this presentation, pharmacists should be able to meet the following objectives. First is to describe the place in therapy for the monoclonal antibodies in the treatment of COVID-19. Secondarily, to identify the challenges with monoclonal antibody prioritization and administration. And finally, to discuss the role of convalescent plasma in the treatment of COVID-19. In terms of pharmacy technician objectives, at the conclusion of this presentation, the technician should be able to list the monoclonal antibodies used in the treatment of COVID-19, as well as describe patient selection criteria for monoclonal antibody administration. And this brings us to our first pre-test question. So we'll circle back to these questions at the end of the presentation. So if you could just think about your answers right now, and hopefully if you get them incorrect now, you will answer them correctly by the end of the talk. The first pre-test question today is, which of the following patients is eligible to receive a monoclonal antibody under the FDA's current emergency use authorization? Choice A is a 78-year-old female with COPD who is hospitalized in the ICU with severe COVID-19. Selection B is a 43-year-old male with a past medical history of a kidney transplant who is hospitalized with COVID-19 on the general medicine floor. Answer C is a 28-year-old female with type 1 diabetes who just tested positive for COVID-19 the day prior and now has a mild cough. Or answer selection D is a 6-year-old male with a congenital heart defect who just tested positive for COVID-19 but is asymptomatic. The next question to think about is, all of the following are challenges associated with monoclonal antibodies except A, unlimited supply, B, need for patient prioritization, C, administration in an outpatient infusion clinic, or D, lack of data in certain patient populations. And again, if you just want to think about your answer now, we'll come back at the end to go over the correct response. Pre-test question number 3, our third and final, is which of the following is true regarding convalescent plasma for the treatment of COVID-19? A, it can be administered in the inpatient or outpatient setting. B, it's a quick and simple manufacturing process. C, there is strong evidence to support its use. Or D, transfusion reactions are a possible adverse effect that should be monitored for. So let's get started with our first monoclonal antibody for the evening, bamlanivimab, also referred to as LY-CoV555 in clinical trials. Bamlanivimab is a recombinant human immunoglobulin G1 or IgG1 monoclonal antibody that's manufactured by Eli Lilly. It was originally derived from convalescent plasma of a patient who was infected with COVID-19. Bamlanivimab works to neutralize the SARS-CoV-2 virus by binding to the spike protein, which is located on the surface of the virus itself. This blocks the spike protein attachment to the human ACE2 receptor, which inevitably prevents viral entry into human host cells. Monoclonal antibodies work by taking advantage of the passive adaptive immunity rather than active immunity, since seroconversion or antibody development in infected patients with COVID-19 typically takes about 1 to 3 weeks after symptom onset. The data leading to the FDA's emergency use authorization of bamlanivimab in COVID-19 patients came from Part A of the BLAZE-1 phase 2 trial. This was a randomized, double-blind, placebo-controlled trial that is currently ongoing. Phase A is concluded, but parts B and C are still ongoing. Part A included 452 patients. Patients were included if they were ambulatory adults with mild to moderate COVID-19 symptoms who had a positive viral test within 3 days of randomization. And as you can see in the flow chart below, patients were randomized 1:1:1:1 into one of 4 groups. The first group was bamlanivimab 700 milligrams. Second group was bamlanivimab 2,800 milligrams. Third group was bamlanivimab 7,000 milligrams. And then our fourth group was the placebo group. This table depicts some of the baseline patient characteristics in both the pooled bamlanivimab arms as well as the placebo arm in the BLAZE-1 trial. As you can see, baseline characteristics were fairly evenly matched between groups. The median age in both arms was around 45 years of age, and the majority of patients included were white with mild COVID-19 disease. Importantly, about 70% of patients included in each arm had risk factors for severe COVID-19 disease, which in this trial included an age of 65 years or older, a BMI of greater than or equal to 35, or a pre-specified coexisting condition, which unfortunately was not further described in the study protocol. As you can also see, the median duration of symptoms in all study arms was about 4 days. This slide depicts the notable results from the trial. The primary outcome in the BLAZE-1 study was the mean change in viral load from baseline to day 11. In the placebo arm, there was a decrease in viral load of 3.47 log copies. Patients in all of the bamlanivimab arms experienced a decrease in viral load by day 11, regardless of the dose administered, with the pooled change in viral load being a decrease of 3.7 log copies. By day 11, the difference was not statistically significant in the pooled arm. However, it was at day 3, which suggests a possible earlier benefit to therapy. A secondary safety endpoint in this study was COVID-19 related hospitalization or ED visits by day 29. A total of 5 events occurred in the pooled bamlanivimab arms versus 9 in the placebo arm. Of note, there were no deaths in this study. The study investigators did conduct a post hoc analysis of about 150 patients that were considered high risk only in the study. And they determined in the post hoc analysis that patients in the placebo arm had a hospitalization rate of about 15%, whereas patients in the bamlanivimab arms only had a hospitalization rate of 4%. And then finally on this slide, you can see the median time to symptom improvement. This was self-reported by patients and was 6 days in the pooled bamlanivimab arms versus 8 days in placebo. Bamlanivimab was granted emergency use authorization or EUA approval by the FDA on November 9th of 2020. And the criteria are listed here. So patients have to have mild or moderate COVID-19 disease. It was approved for adults and pediatric patients 12 years of age and older weighing at least 40 kilograms who had a positive viral test for the SARS-CoV-2 virus and who are at high risk for progressing to severe disease and or hospitalization. So at this time, bamlanivimab is not emergency use approved for hospitalized patients, those who require oxygen therapy due to COVID-19, or those who are on chronic oxygen therapy but have an increase in oxygen from their baseline due to COVID-19 disease. There was a trial, the ACTIV-3 trial, that was trying to evaluate the use and the role of bamlanivimab in the hospitalized patient population, but it was actually halted early in October 2020 due to a lack of benefit observed between the treatment arms as well as the placebo arm. As you can see here, the FDA does have specific guidance on who qualifies as a high-risk patient. They include patients with a body mass index of greater than or equal to 35, any patient with chronic kidney disease, diabetes, immunosuppressive disease, those currently on any immunosuppressive treatment, as well as any patient who is 65 years of age or older. As you can also see, they have more specific criteria for those ages 55 and older. They must have at least one cardiovascular disease or hypertension or COPD or another chronic respiratory disease. And then in the age group between 12 and 17 years of age, they must meet one of the following criteria to be considered high risk. And that includes a BMI of greater than or equal to the 85th percentile, sickle cell disease, congenital or acquired heart disease, a neurodevelopmental disorder, a medical related technological dependence, which for example would be a tracheostomy, patients with asthma or a chronic respiratory condition that do require a daily medication. In terms of administration, bamlanivimab is infused as a single 700 milligram intravenous infusion over 60 minutes. It is supplied as a solution that does require dilution in anywhere from 50 to 250 milliliters of normal saline prior to administration. The FDA's EUA does mention that it should be administered as soon as possible after the positive viral test results and within 10 days of symptom onset. Additionally, the EUA states that there is required clinical monitoring for adverse reactions during administration of the infusion and for at least 1 hour post-infusion. In terms of adverse effects, the EUA specifically mentions hypersensitivity, including anaphylactic and infusion-related reactions. They also state that there is a potential for clinical worsening after administration, and it's really unclear at this time whether it could be related to bamlanivimab itself or simply progression of COVID-19 virus. In looking at the BLAZE-1 trial adverse events, there were 23% reported in the bamlanivimab arms versus 26% in placebo. The most common adverse event experienced was nausea, followed by diarrhea and dizziness. However, it occurred in less than 4% of patients in the bamlanivimab arms. Regarding the use in special populations, unfortunately, we do have insufficient data at this time in pregnant patients as well as those that are breastfeeding. So the EUA states that it could be a consideration for administration if the potential benefit will outweigh the potential risks. And at this time, there are no dose adjustments needed for renal or hepatic impairment. There are two major organizations that issued treatment guidelines for COVID-19. Those being the NIH, or National Institutes of Health, as well as the Infectious Diseases Society of America. Both have issued specific statements relating to bamlanivimab, and you can see both on this slide. Per the NIH, there are insufficient data at this time to recommend either for or against the use of bamlanivimab for the treatment of outpatients with mild to moderate COVID-19. Similarly, the IDSA has a statement, and they recommend that among ambulatory patients, they're suggesting against the routine use of bamlanivimab. And as you can see, this is a conditional recommendation with a very low certainty of evidence. The IDSA goes on to further elaborate that in patients who are at increased risk of disease, as defined by the FDA, bamlanivimab is a reasonable treatment option as long as the patient puts a high value on the uncertain benefits and a low value on the uncertain adverse events of this treatment option. So that brings us to our second monoclonal antibody. This is actually a combination of two of them, casirivimab and indevimab, otherwise known as REGEN-COV2 in the clinical trials. Casirivimab and indevimab are two recombinant human monoclonal antibodies manufactured by Regeneron Pharmaceuticals. They work by binding to non-overlapping epitopes of the SARS-CoV-2 spike protein receptor binding domain, to essentially block the binding of the spike protein to the human ACE2 receptor. And similar to bamlanivimab, they really work to prevent this virus from getting into host human cells. The data supporting casirivimab and indevimab came from this phase 1 and phase 2 trial, which was a randomized double-blind placebo-controlled trial, including 799 patients. Ambulatory adults with mild to moderate COVID-19 symptoms who had a positive viral test within 3 days of randomization were included and were randomized to either casirivimab and indevimab at a dose of 2,400 milligrams, casirivimab and indevimab at a dose of 8,000 milligrams, or the placebo group. The demographics of randomized patients in the study are included here for you. I did want to point out that over half of the population randomized to the treatment arms were of Hispanic or Latino descent, and about 15% were Black. Additionally, over 60% of patients in each arm had a risk factor for hospitalization, which in this study was defined as an age of 50 years of age or older, obesity, cardiovascular disease, other chronic lung and metabolic diseases, or an immunosuppressive disease. Of note, this study did also perform serology or antibody tests at baseline, and you can see in the table that a higher percentage of seronegative patients, so those that did not have antibodies already to COVID-19, were included in the treatment arms compared to the placebo arm. Overall, as you can see, both treatment groups did show a greater viral load reduction than placebo. However, the decreases did appear to be driven mostly by the patients in the seronegative population, as well as those with greater baseline viral loads. The secondary endpoint of medically attended visits related to COVID-19, the study defined this as any visit, be it a telehealth visit, an emergency department visit, or even a hospitalization. You can see here was at day 28, it was 50% lower in the antibody arms compared to the placebo arm. And finally, in the study, the median time to symptom improvement was 5 days in the pooled treatment arms versus 6 days in the placebo arm. Casirivimab and imdevimab was granted emergency use authorization by the FDA a couple weeks after bamlanivimab on November 21st of 2020. The criteria are identical to that of bamlanivimab, so those for the treatment of mild to moderate COVID-19 in adult and pediatric patients 12 years of age and older who have a positive viral test for SARS-CoV-2 virus and are at high risk for progressing to severe disease and or hospitalization. And the high risk criteria that's defined by the FDA is identical to that of bamlanivimab. When looking at the use of this Regeneron product in hospitalized patients, there is an ongoing study, and there was a press release submitted a couple weeks ago from preliminary data, and it does appear to be promising in those that are hospitalized and on low flow oxygen. So we are anxiously anticipating those results. In terms of administration, casirivimab and imdevimab are administered as a single 2,400 milligram intravenous infusion. This is comprised of 1,200 milligrams of casirivimab plus 1,200 milligrams of imdevimab over 60 minutes. They are supplied as solutions in individual single dose vials that do require them to be combined and diluted in 250 milliliters of normal saline prior to administration. And I did want to point out the packaging and the labeling of these two products, as it can be kind of confusing and difficult to see. So in this picture I've included, you'll notice that the names on the package labeling are actually not casirivimab and imdevimab. They use that of the products in the clinical trial, so casirivimab being Regen 10933 and imdevimab being Regen 10987. So you really have to look really closely to make sure that you're pulling the correct product, and pharmacists and technicians upon compounding and upon verification really need to make sure that they're looking closely to prevent any medication errors. In terms of clinical monitoring, it's the same for bamlanivimab, so the required monitoring during infusion and for at least 1 hour after the infusion ends. And then similar to bamlanivimab, this should be administered as soon as possible after positive viral testing and within 10 days of symptom onset. Adverse effects are also similar to bamlanivimab with hypersensitivity, including anaphylaxis and infusion-related reactions possible. In the clinical trial, they only mentioned serious or special interest events, which was low in the treatment arm as well as placebo arm. And the special interest events they defined as a hypersensitivity or infusion-related reaction. Similar to bamlanivimab, we unfortunately do not have any data on these special populations at this time, including pregnancy and lactation, and there are no dose adjustments needed for renal or hepatic impairment. In terms of guideline recommendations for this product, they're very similar to bamlanivimab. So the NIH recommends that there are insufficient data at this time to recommend for or against. And similarly, the IDSA recommends against the routine use of casirivimab and imdevimab due to a very low certainty of evidence. However, they mentioned that in ambulatory patients who are at increased risk, defined by the FDA, it's a reasonable treatment option as well as the patient is aware and an informed decision is made and the patient agrees to the risk with the potential uncertain risks as well as benefits of the product. So I did want to touch on some of the challenges with these monoclonal antibodies in general. The first is supply. These monoclonal antibodies are very difficult and time-consuming to manufacture. As of today, the federal government has purchased 950,000 doses from Eli Lilly of bamlanivimab and 300,000 doses of casirivimab and imdevimab from Regeneron. However, due to the time it takes to manufacture, we do not have all of those doses currently available, and it is projected to take some time until we have the full stock of those products available to our patients. In terms of prioritization, I did mention that the FDA has very specific criteria for who qualifies as a high-risk patient. However, even with that specific criteria, it is still too broad for the supply that we currently have on hand. So when you think about it, if we include any adult patient who's over the age of 65 with COVID-19 disease, it's a lot of people that are going to be eligible to receive these monoclonal antibodies. And that's not even including anyone with a comorbidity or a chronic immunosuppressive disorder. So with the lack of supply and then the limited supply that most institutions have, we really need to make sure we're prioritizing even further beyond that FDA criteria to really figure out who is the highest risk patient population and who should be prioritized to receive these products first. Access is another issue. As you've probably seen in the media, there are reports of unequitable distribution of these monoclonal antibody products among hospitals across the country. There are some hospitals that are said to have these products just sitting in their freezer with no patients to administer them to, whereas other hospitals that are in need of them, unfortunately, have not received any shipment or supply. And access is definitely an issue. Getting them into especially areas with more lower income populations who we know are hit harder with COVID-19 disease will be important in the distribution process going forward. Provider comfort is another challenge. So when you think about these, again, like I mentioned, they're eligible for outpatient administration only. So the people that are going to be prescribing these are most likely going to be primary care providers as well as emergency medicine physicians. And when you take into account who typically prescribes monoclonal antibodies, it is not these primary care providers or emergency medicine physicians. So a lot of them may not feel as comfortable or may not be as knowledgeable about a monoclonal antibody product. So this is where provider education will be very important moving forward. As I mentioned earlier, there is a lack of data in certain patient populations, including those pregnant patients as well as breastfeeding. In terms of outpatient infusion clinics, this will definitely need to be taken into account. So most hospitals or other outpatient infusion clinics will have to have a designated and segregated space to set up their infusion clinic in. So all of these patients coming in are going to be COVID-19 positive patients. So you cannot have them near your typical patient who receives monoclonal antibody infusions that are immunosuppressed patients. So really making sure you have a designated, segregated area away from other patients is going to be important. So space considerations will need to be taken into account. The administration time is also another challenge. So like I mentioned, it is a 1 hour infusion. And then it requires, per the EUA, a 1 hour post-infusion monitoring time at minimum. So I know at my institution, we're blocking patients out in 4 hour appointment windows. And the longer the time it takes, the less patients, unfortunately, can be seen that day and receive their monoclonal antibody infusion. So administration time is definitely a limiting factor. And then another challenge that's important to consider is how effective these monoclonal antibody products are going to be with the new emerging COVID-19 variants that we're hearing about every day. There are some preliminary thoughts that potentially decreased efficacy with bamlanivimab, also probably some decreased efficacy with casirivimab and imdevimab, but maybe a little bit less so since it's a combination product. However, these are all just thoughts and predictions. We definitely need more studies in the future to determine how effective they'll be with these new COVID-19 variants. I did want to also mention briefly the cost of these products. So it costs about $1,500 for the government to acquire these monoclonal antibodies per dose from the manufacturers. However, under some federal government deals, they are actually free of charge for patients, with the exception of some private insurance companies who may require a copay for a cost of administration. Luckily, with Medicare patients, they do not require any copayments for administration costs, so it would be completely free to those patients that qualify for Medicare. There are a lot of other monoclonal antibodies that are currently in development. There's a really cool site that I have linked here at the bottom. Chinese antibody tracker for COVID. It gives you up-to-date real-time reports of how many are currently in development in all different phases. So as of today, there are 217 antibodies in the discovery and development phase for over 62 viral targets, 79 antibodies that are in clinical trials, that being phases 1 through 3, and at least 29 countries and 291 companies currently developing antibody therapeutics. So we can probably expect to see some more approvals in the near future. And finally, I just wanted to briefly touch on one slide, convalescent plasma, and compare and contrast that to monoclonal antibody therapy, since they are similar, but there are some notable differences. So like the monoclonal antibodies, convalescent plasma does take advantage of that passive adaptive immunity. It is not manufactured, however, it actually comes from donated plasma from recovered COVID-19 patients. Convalescent plasma contains a wide variety of SARS-CoV-2 antibodies that may aid in suppressing viral replication as well as the inflammatory response of the host. It has been available under emergency use authorization since August. However, unlike the monoclonal antibodies, convalescent plasma is currently only EUA approved in hospitalized patients. The dosing is typically 1 to 2 units once, with an additional dose being given with the discretion of the provider. In terms of adverse effects, transfusion reactions are the most common. They do remain quite rare, but those are the most common that have been seen in clinical practice as well as the trials. And in terms of guideline recommendations, there is, similar to the monoclonal antibodies, insufficient data at this time to recommend for or against. And a lot of the clinical trials that we've been seeing, unfortunately, are not showing a great benefit in mortality reduction or progression to severe COVID-19 disease as we would have liked. So the place in therapy is still fairly murky for convalescent plasma. So this brings us back to our test questions. So test question number 1, which of the following patients is eligible to receive a monoclonal antibody under the FDA's current EUA? Let's see if I can see the chat here. Good, I have a response for C, and that is correct. So C is the correct answer here, the 28-year-old female. So if you recall, both monoclonal antibodies are authorized for use in outpatients only, so that automatically eliminates choices A and B. And then we want patients that are at high risk for disease progression. So this patient does have diabetes and meets that criteria. And then if you recall, the age cutoff is 12 years of age or older. So choice selection D was eliminated since that patient was 6 years old. Next post-test question, all the following are challenges associated with monoclonal antibodies except, pull up the chat here, A, good, unlimited supply. So like I mentioned, supply is limited by the manufacturer distribution. Unfortunately, these are more difficult and time-consuming products to manufacture. So until we have an unlimited supply, we're going to really make an effort to prioritize these monoclonals to our highest risk patients. Finally, our last question, which of the following is true regarding convalescent plasma for the treatment of COVID-19? Good, seeing the correct answer as D. So transfusion reactions are a possible adverse event that should be monitored for. So like I mentioned, they do appear to be rare, but they are possible, and these can include hypersensitivity reactions, difficulty breathing, fever, and hypotension. So here's just a quick summary with all of the take-home points. As you recall, bamlanivimab and casirivimab and devimab are currently the only 2 monoclonal antibodies granted EUA status in the US. Both are authorized for the treatment of mild to moderate COVID-19 in patients at high risk for disease progression or hospitalization. Administration is via an IV infusion over at least 60 minutes. Safety data does appear favorable, but we currently have a lack of data in those special populations. There are many challenges associated with monoclonal antibodies, including supply, access, and administration, to name a few. Finally, convalescent plasma is available under the EUA for the treatment of COVID-19 in hospitalized patients. With that, I'll take any questions. I did want to point out that there are many studies that are ongoing with these monoclonals, including their use in hospitalized patients. Casirivimab and devimab is also being looked at as a potential prophylactic agent for potential prevention of COVID-19 and those that are household members of someone who is infected. And then bamlanivimab is also being studied with another monoclonal antibody being developed by Eli Lilly as a combination product similar to Regeneron. So lots of information, I'm sure, to come in the future. And then here is my contact information. If you do have any further questions, feel free to email me. I'd be more than happy to answer anything. Now let me stop sharing so I can see the chat better.
If you have a question, go ahead and raise your hand. Actually, Jenny, you've got your hand raised. You can go right ahead.
I was clapping.
Oh, you were clapping. Okay. Abby, you do have your hand raised. Go right ahead.
Yeah, thank you so much, Garth. This is a great presentation. And I'm also going to clap as well. Great presentation, Christy.
Thank you.
Going back to your idea about there is actually a lack of equity and access to these products, what kind of effective strategy from your perspective would be helpful to get these products to the patient who needs it the most? Because at the end of the day, we're all going to be impacted if we cannot get rid of the COVID, right? So it's not just these patients, it's pretty much everybody.
Yeah, that's a great question. I think there are so many people out there trying to find the right answer to that question. I think really we just need more guidance and more infrastructure, whether it be from the federal government, the individual states, or the local public health departments. But they were emergency use authorized on a Friday. And then we had to quickly, as an institution, try and figure out our protocol, who we'd prioritize, how to build this order in Epic, where we were going to infuse them. So it was all last minute planning. So there wasn't really much guidance from anyone coming from the state or the government. So I think just trying to have a plan in place. And once an institution does find a method that's effective, to try and share it with others just to educate everyone. But that is definitely something that needs to be worked on. But I think just we need more guidance and more planning from higher up in the government or the states or the public health departments.
Any other questions or comments? You can either type them in the chat or hit the raise your hand function and we'll recognize you.
Looks like there are some questions from earlier. Used with much success within the Federal Bureau of Prisons. Are you tracking the data? Are there clinical studies with the Native American population? That's a good question. I'm not sure if they're including those populations now. They were not well represented in the initial studies, but I'm not sure if the ongoing studies will include those patient populations. Hopefully they do for more diversity. What is the shelf life of the product? That's another good question. So once it's been reconstituted and diluted, it's available and stable for about 24 hours in the refrigerator. But otherwise, I'm not totally sure of the expiration on the product itself coming directly from the manufacturer. But once it's been diluted, it's 24 hours. Any other questions? I'm not related to Carl Bertram. Good question.
All right. Well,
thank you so much again for having me. Feel free to email if you do have anything that comes up.
Carl may claim you though. You're so brilliant. Carl may try to start claiming you. So
oh, thank you. I'll keep my eye out.
Yeah.
all right. Let me. So this is, is our monthly town hall. So again, feel free to unmute your line if you have a question or to raise your hand. As I quickly go through some of these slides, I will try to address, I need to pop out the participants so I can see that. And also the chat. All right. So as we've always begun each of our COVID town halls, I do want to go ahead and just quickly review some of the global stats. It's interesting to see now that we're at 104 million cases of COVID-19. When I was updating the presentation, we were just at 87 million in January. Let that sink in for a little bit. And we're still at 26 million cases here in the United States, and unfortunately quickly growing. But we're still holding around that 50% have recovered. And that continues to be good. We know it doesn't reflect here any second infection rates or any of the other issues that are going on with patients who are having a longer recovery time. But it just kind of give us a kind of a step back to take a look at the magnitude of what we're dealing with. Here in Illinois, this dashboard is updated to now include some of the vaccine data. And I know it may be a little bit hard to read on your screen, but confirmed cases as of today was 3,300 cases, so 1.1 million. We just, I think in the last week or two, we moved over that 1 million total case number. And we're going to go into vaccinations here a little bit more in depth here in a minute. So as you all recall, back in December, for most of December and the early part of January, we were all in Tier 3 mitigation to really stamp out a dramatic increase of case spread that we saw in all regions of the state. Luckily, mitigations were ended for Tier 3 back on January 15th, and 10 of the 11 regions have now moved to fully phase 4 of the Restore Illinois program. And if you remember, the plan includes 5 phases, and the 5th phase is what we'll be at once we complete the vaccination effort here in Illinois. Right now, Region 4, which is the Metro East area, is still in phase 3, Tier 2. Because of the caseload that they're still experiencing and the stress on the hospital system in Region 4, which is the Metro East area. Now we've started the vaccination effort, and now the department is updating information almost daily on the vaccine effort. You'll see that Illinois has been giving a total of 2 million doses. We have administered only 50% of those doses. In the long-term care sector, which has been a lot of focus here in the press lately, it's been just under 500,000 doses and only 175,000 have been administered. So that's less than 35%. That's pathetic. And I think we really need to push and impress upon our colleagues. And really, when we start looking at phase 1A, it is very disheartening to see the number of healthcare workers and staff that are not taking the vaccine. We have an obligation to our patients to protect them, which means we have to protect ourselves. And I know most of you on this call are the choir, and I'm preaching directly to you all, and I applaud you because I know personally that almost all of you on this call have had your vaccine, and I appreciate that. But we really have to work with the vaccine hesitancy and that our peers may be experiencing. We've seen, continued outbreaks in long-term care because a lot of long-term care staff are not getting the vaccine. It just shakes me to my core that that's even considered to be an option. It was such a vulnerable population. We have to be stepping up to what we need to do for our patients and getting vaccinated. And I know it's been a slower rollout than we'd like. I know a lot of that has to do with barriers of vaccine being moved around or not being released as appropriately. And I appreciate all the pharmacists that have been able to step up. But we have a lot of pharmacists in the state that can still continue to be greenlit. And as you've seen in the press, we've been pushing and advocating for that, not only with the department, but also with other stakeholders to impress upon them that we need to be getting Illinois to a ready status instead of a reactionary one. And we need to be completing those eye care registrations. And if you are a pharmacy that still has not completed eye care, you have one thing to do tomorrow, and that is to work on your eye care. We have been talking about eye care for years and encouraging pharmacies to be members of eye care. And be submitting your records to eye care. And we really, really need you to start doing that. That's our biggest barrier for getting our argument for more pharmacies to be involved. I know there's a lot of confusion. I have a couple slides from IPHA that I will go through, and Mitch may get mad at me a little bit for using a couple of them, but I think it helps with describing some of the situation out there. But I really want to make sure that everybody is ready. And I know there's a lot of confusion between federal networks and state networks. And it's even confusing with you're signed on eye care, but you still may not be ready because you don't have a COVID provider ID. So those of you who have signed up through your federal program, so either through CPESN, through Health Mart, through Medicine Shop, you have to have an eye care registration. You should not have been allowed to register if you did not have an active eye care registration. In addition, you need to have a COVID PIN ID. If you do not have that, you need to work with eye care in obtaining one, or work through your federal partner to make sure it's assigned. Either way, eye care needs to know about it. So please make sure that those numbers are being passed along, or that they're at least being informed, and that you're filling out all the proper forms. If you are working as wanting to be just a state available provider, you need to follow and fill out the forms as we set out in the VaxFax about a week ago, and we'll include it in the one that'll be going out later this week. But you need to fill out your state provider COVID form in addition to your CDC provider form. Your CDC provider form is not enough. So please make sure, if you have issues with eye care, please email me. We can help with contacting eye care staff and helping facilitate the resolution of those issues. And those of you who have your eye care number and your COVID number, I know you're kind of feel like you're on standby, and that's unfortunately where I think we're going to have the network at the moment. But I at least want you to ready status so when more supply comes into Illinois, we're ready to green light you and get you the vaccine into your communities. Please feel free, and I encourage all of you, if you have not, engage your county public health department directly to see how you can best assist them. A lot of counties, specifically the further south you get of Springfield, do not have that many staff in their public health departments, and they're overwhelmed. This can be an opportunity for you to be able to be greenlit ahead. We do have a number of members who are working with county public health departments directly and actually helping vaccinate in phase 1A, both healthcare worker and long-term care. So please be reaching out to your county public health. Just to give you an idea of Illinois vaccine details, again, we're just showing you that data, but this is where really everything hits the road. We've got 12.7 million people in the state, and we only have 244,000 people fully vaccinated, less than 2% of the population. As I have said, and as I've continued to say, and I've tried to really impress upon every single reporter, I think it's irresponsible what the media has been doing with trying to make people think the vaccine's here, so everyone, it's going to be over soon. This is going to be a very, very, very long road. And if we continue to have the barriers and the obstruction from state and federal government, it's going to be even longer. And we really have to impress patience upon when we in our discussion with our communities, and understanding that this is going to take time. I I really want to kind of show this just as sheer as numbers. This is from version 5 of the vaccine plan from the state. Yes, the state does have a plan, even though it doesn't look like they have one. Phase 1A is 850,000 people. And we really haven't done very well with getting all that done, getting all them vaccinated. And that's still the eligible people. And this is where we really need to work back with our peers and really question why they haven't got the vaccine. But if we don't get these issues solved that we're having now, and that's include with having number of pharmacies, having enough network spread across the entire state of vaccinators, we should not have activated phase 1B. It was immature of the state and premature of the state to activate phase 1B so early and to add on additional people, 65 to 74, in direct contradiction to ACIP guidelines. That puts 3.2 million people into the pool for the vaccines. And if we don't fix the problems with the state now, it's going to continue to multiply and it's going to get worse. We're going to get more aggravation from the public, and we're going to get aggravation from providers, and we're going to see acceptance of the vaccine plummet. And especially when we start to try to get vaccine into communities of need and communities of color. We have to start getting our act together as a state when it comes to this vaccine. Let's see here. I had not seen where people were putting comments in here. I was going on my soapbox too much, so let me get to your questions here real quick. Sam, slightly off topic. Anyone else feeling lousy after their second shot of COVID? I'll let you know tomorrow, Sam. I got mine this morning. I know some of you have experienced that, and you're sharing that, and I appreciate that. Julie's asking, why is the vaccine not mandatory for long-term care employees and residents? I think that's a very good question. I'm really surprised more employers haven't done it. It has really surprised me as many employers who already have mandated policies for the influenza vaccine are not doing the same thing for COVID. It's very interesting. Sam, the delay between submitting registration and approval for ICARE is crazy. I agree with you. We've actually have been in touch with staff members from additional departments outside of IDPH because they're now tasking other staff members and other departments to help with the information and procedural overload. Rupesh, if people over 65 wanting the vaccine, how can we direct them to get them quicker? It's a challenge to get ICARE registration completed. I agree with you on the ICARE registration. For those over 65, I almost have to say at this point, it depends on your county. Like right now here in Sangamon County, you have to be 85 or older. They're doing it in a more tiered approach for availability of appointments. So you need to take a look at that on a county by county basis. And that's part of the problem. We have 102 counties in the city of Chicago, so we have 103 approaches to this vaccine and no clear direction from the state. Julie said, you've had one facility who had it mandatory and it seemed like others didn't realize that they can make it mandatory. Well, an employer can do whatever they want. Scott, any idea how long, once ICARE approved the COVID part, will with the CDC issue the COVID PIN? That's been the biggest, one of the issues that those of you who are waiting on your COVID PIN from ICARE, I actually need some feedback from you because that's one of the things that ICARE is saying has been their biggest hurdle. APH, I brought this up at our APHA. Every 2 weeks, APHA Government Affairs has a conference call with the state execs. And we brought this up on the call. We weren't the only state that was having this issue. So I do need to know some of the issues you've had and how long you've been waiting to get your COVID PIN. So if you can email me that separately. Sam, send me an email to remind me to talk to you about the ICARE tomorrow. Andrea said, I think many are holding off on making it mandatory because it's under EUA. I get that. This is a hard situation, but you know, we've seen examples of long-term care facilities that have exploded in infections because the staff aren't protecting the patients. I quickly want to go through with these. I'm actually going to step out of this for a second. Back to the recording here. And back into the chat. Any questions? Anyone can raise their hand and or open your line, and we can go ahead and answer any other questions or comments. Everybody's very quiet. Are we all tired of the first part of the month? I know it's been a rough one this week.
Maybe everybody's recovering from their second doses, Garth.
It could be. I'm waiting for it to hit me. That's why I'm kind of going right ahead full steam until it hits me. Someone said my technicians were impressed with the program today. Well, great, Scott. I'm very glad to hear that. I was getting ready to bring that up. We had our first 30 technicians in our first cohort for the IPHA immunization programs for technicians, and we'll be doing their assessments. So if you know of anyone who's a technician who is wanting to step up to be part of this groundbreaking and historic effort and want to be some of the very first technicians in Illinois to administer vaccines under their new authority, please get in touch with us. We'll be glad to set up another program. I was very proud with the interaction between the individuals we had today. It was a great conversation, and I look forward to working with them over the next 2 days as we go through their skills assessments. And also, if you know of anyone who as pharmacist who needs to take their immunization program, or is someone who hasn't done immunizations in a while and needs to do a refresher, IPHA is providing the course again virtually on February 24th. You can sign up on the website, and then we still have plenty of seats for that program. So not just virtual seats, but actual seats too. So, we are going to be offering these programs again on a more rotationary basis, but it is going to be based on needs. So don't wait. I know a lot of times everyone goes, well, it's on the day I work. This is one of those times you really need to make the opportunity and make it work for you on your schedule. We have, we can't just be offering the program for a couple people at a time. So we really want to make sure we have full classes for these programs. And again, I was very impressed. We had 30 in today, and they were all very enthusiastic. And we had about 25 or 29 pharmacists in our pharmacist program in the beginning of January. And look forward to working with the ones coming up here in February. I need to go back. Dre, if you have the link for that survey, if you could put it in the chat while I try to find the one you sent me.
Just give me 1 minute, Garth. I'll send it right away.
Actually, I got it. Never mind.
Okay.
I found it. Our April, if you can click on this link and fill this out, you don't have to fill it out right away, but at least click on this link so you can fill it out afterwards. Our April program is going to be on legislative concerns concerning in relation to COVID, and it's going to be done by a pharmacist attorney. And I think right now it's Jay Bogdan, but I'm not sure if he's the speaker. So he's asked for your assistance on what issues you'd like to have discussed. So if you don't mind filling out that survey. And just as a reminder, this is our monthly town hall, so the first Wednesday of the month. And we will next month is on health disparities and issues with health disparities in communities in relation to COVID. So we're going to continue with COVID for the next couple months. That shouldn't really be surprising to anyone, but please keep an up to date on all of our emails that are coming out. There's a lot of information happening very quickly. Also look in your email boxes tomorrow or Friday for the brand new electronic edition of Illinois Pharmacist Online. We're bringing back the journal. It's going to be in an electronic format with only a once-a-year printing for annual conference. But we're going to work on a bi-monthly edition, and then as interest grows, we're looking at hopefully moving it to a monthly. But look for that in your mailbox, and we like to have feedback on the new design and layout of the electronic journal. Emily, any tips for having to tell people that you can't give them a vaccine immediately? I'm in a community and it's getting draining having to turn people away. It's just really discussing with them that this is a marathon and not a race. I know people are really wanting it. I am overjoyed and enthusiastic by how much people are wanting it. As much as we feared that there was going to be such general population hesitancy, it's been very encouraging seeing people's want for it. The problem is we're going to have to hold that, and hopefully we don't lose them by the time that we actually get enough supply. Sam has suggested, doesn't your EFR literally tell people Walgreens staff can't approve people for COVID vaccine over the phone? That's something that, you may want to discuss on that and work with your supervisors on that part. But I really appreciate all the hard work you're doing with reaching out, volunteering. There's been talks of trying to do a student pharmacist run clinic here in Springfield here in the coming weeks. So try to look at those opportunities, even if it's where you can help mentor and just supervise some students or technicians at a clinic. Please take those opportunities. We're working on a standing order right now so that doctors and nurses and pharmacists can supervise each other's students in these clinic, but that hasn't been approved yet. So we're trying to make it a little bit more flexible. Dentists are getting on board to be able to assist with immunizing as well. So we're trying to get everybody in the immunization neighborhood ready to go. Yeah, Badrea said health departments control the vaccine and we have absolutely no control over it. And again, that's true. The counties really have the control over a lot of the supply. And again, that's part of the problem. But we just really continue to press upon people to look at the state's coronavirus website on the vaccine section. It does talk about how they can contact the pharmacies and other locations to be able to make appointments. Please, again, continue to encourage and work with your county health departments, especially if those are doing the free-for-alls and not doing any appointments, because they're going to need all the help they can get. Even in my own home county, where we had just 120 doses available, they had 85-year-old people lining up at 4 a.m. waiting for a 1 o'clock clinic. And that's outrageous because they would not do an appointment-based model. So just continue to work and try to help out the best you can. So I'll get off my soapbox, and any final comments? If not, we'll let you guys go until March. All right. Thank you, everyone. I really appreciate everything you're doing, and we'll see you guys all next month. Thank you.